associated with adverse outcomes, including adverse cardiovascular outcomes. So that was something I wanted to share. And moving on, I've been given this opportunity by Eli Lilly to present two wonderful cases. They are very everyday cases, but yet there are pertinent lessons to learn from them. So let me go through the first case. Miss Neha, 33-year-old female. Uh, can you hear me?
Yes.
Well, so I would say extremely obese and indicated by the weight as well as the BMI, 51.56 kilogram per meter square. And like I think
I'm
Mudit
in a
also
conference in
mentioned,
Hyderabad, so I will be free by another 1 hour. Then I can see you. Only then I can see.
I can hear some other sounds also. Am I the only one speaking, or is there somebody else also logged in?
I'm in the conference half.
We can hear you.
Tech team, yeah, if you can mute the other person, it's disturbing me. Okay, so the height is 160 centimeters, weight is 132 kilos, and indicated clearly by the BMI is severely obese. Go on. She's only 33, but of course, a comorbidity of diabetes and hypertension as well. And she is being maintained on telmisartan for 40 milligrams given once daily. HbA1c is at 7%, and blood pressure is generally well maintained at 130 by 80 millimeter mercury. And she was on tenaligliptin and metformin combination, half given twice daily. So clearly not my ideal prescription when I saw this patient. But today we are in the era, of course, previously if I had seen her, I would have counseled her definitely to have a more weight-centric approach to diabetes, but also would not have been able to offer really good, potent options to her. But today we are in that era where we have the GLP-1 GIP combination, tirzepatide. Move on, please. And I discussed the need for having this weight centric approach to her diabetes as well. Because a lot of times, most patients consider this as a cosmetic issue. They just feel they are probably a little overweight or healthy, but they are more concerned about the sugars. Rightly so, they should be concerned about sugars, but we know what's driving diabetes in her, and it's probably the weight gain. So definitely talk to her about a transition in the prescription, because we know that tenaligliptin and metformin both are very, very affordable options, whereas what I was going to give her was probably a little bit that required priority on her part. So explain to her that definitely the therapy I was suggesting had better weight loss potential and greater HbA1c reduction and better metabolic control with all the benefits as well as adverse effects spoken to her about. So started with the dual GIP-GLP receptor agonism, the synergistic effect that we get with tirzepatide use. Next, please. And transitioned her and suggested to her that HbA1c, less than 6.5 is also okay, but definitely much lower or should go into, the normal glycemic range. She's young and with a good amount of weight loss that was going to be possible for her. And weight loss, of course, made a modest degree of, goal setting for her with 5 to 10% to begin with. And then, of course, definitely spoke to her about even CGM use, because today CGM also helps us with a lot of understanding of the glycemic peaks and troughs. So it's a very, very helpful tool. And I am a believer, so I would love to counsel every patient that I see with CGM as well. So here we were able to control the postprandial hyperglycemic peaks and also weight loss through appetite regulation. And the therapy chosen clearly was tirzepatide. And as suggested by the company itself, we started with 2.5 milligrams given subcutaneously on a weekly basis for 4 weeks, and then escalated to 5 milligrams per every week for 4 weeks. Of course, before initiating the need for weight loss medications and that, all the adverse effects of having such extreme weight gain uh, was explained and discussed in detail with the patient. The available options were also discussed. The mechanism by which tirzepatide works, the efficacy expected, risk benefit ratio, as well as the effects of the drug. Because a lot of patients come back at the first follow up and they will say, but I'm just not able to eat, and I feel extremely upset about it. So basically, the point I'm trying to make here is that the expectations have to be set really well when you start on this kind of therapy. And I'm sorry to say, a lot of physicians take obesity management or weight loss therapy as they take it very lightly. There's no counseling offered, or it's just a prescription. I would suggest that if you're not dedicated towards obesity management practice, then best not to actually do that, because then you are doing a disservice to the patient. So that initial counseling is extremely important, discussing everything about the drug, the expected pharmacological effects, how it works, what are the clinical benefits that we would expect, what is the risk profile, what is the risk benefit ratio, and the need, the patient centric need also should be explained well. When you do that thorough counseling, the patient acceptance of therapy is much better and the adherence is also much better. And I'm sure all my expert colleagues sitting here would probably agree with that as well. Next, please. So yes, we did observe she was a good responder, and we did observe weight loss as we moved on from 2.5 to 5 milligrams of tirzepatide given once weekly for 4 weeks. And the patient motivation level was really coming up, and she was very, very dedicated to lifestyle changes as well. So there was definitely acceptance of tirzepatide, and she felt more confident about moving on to this journey, because again, setting the expectations right is important, and explaining to the patient that there are no benefits to be expected overnight. It is a long journey. So she was more confident about walking on this path, and we made a shared decision. Again, that's a point that was discussed earlier, that we should escalate from 5 milligrams to 7.5 milligrams, and she definitely felt good about starting that new dose. And after 4 weeks further, I did escalate to 10 milligrams per week as well. Let's remember her BMI was almost 52 kilogram per meter squared. So she is one of those patients who would probably require higher dose, and rightly so. Next. HbA1c after 4 months. So this is, we continued the therapy, gone up to now 10 milligrams. Definitely better appetite control and better control of sugars as well. And we did an intermittent CGM, which I have not shown here, but she did well on that. And A1C has nicely come down from a 7%, which wasn't so bad to begin with, but it's come down to a 5.4, which was my initial discussion with her, that for someone like her, I would want her to, besides the weight loss, get into the normoglycemic range. So here is diabetes remission in 4 months with tirzepatide. Next, please. HbA1c of 5.4, and look at the weight reduction from a 132 kilograms. And she did mention to me when she had come earlier that she had found it impossible to stick to any weight loss diet that she had consulted so many people and so many things, and she was never able to stick to it for longer than a month or so. And this is the first time that she had been consistent for 4 full months. And very nicely, came up for each follow-up requested, escalated the dose nicely, was able to manage the side effects also, and control her eating, as well as initiated walking and, getting more and more physically active. And she was at a good 117.7. This may look modest to most clinicians. However, it's very significant because from the patient perspective also, first of all, it's a 10.8% weight loss in 4 months. But from the patient point of view, the needle that just wasn't moving has now come down, and come down by a good 10%. So look at the motivation there itself, and look at all the metabolic benefits that the patient has first experienced firsthand. Next, please. So this is this is like a quick summary of the BMI reduction also, and the weight coming down from 132 to 117.7. She in fact even said that I haven't weighed this much in so long. So, this is really what we're looking at. Of course, a body composition analysis also would have helped, and we have done it. I probably haven't appended it here, but we have done it, and but not immediately in 4 months. We haven't repeated it. I usually repeat it in 6 months. Next, please. So in all, if I had to summarize this particular case, tirzepatide definitely showed superior glycemic and weight outcomes versus oral GLP-1. And we started at the recommended dose of 2.5 milligrams weekly, titrated up to 5, and then eventually got her up to 10 milligrams per week. And in the first 4 months that I followed up, of course, the patient is on long-term therapy and continues to get this therapy, and she's really thrilled with the response that she has seen. But she's definitely in diabetes remission. And as far as tolerability goes, there was gradual titration, minimizing all the gastrointestinal side effects, definitely encouraging her to adhere to the therapy. And multidisciplinary counseling and follow up are actually the tenets of weight loss therapy. Like I said, that if you're not dedicated enough to offer that kind of counseling and discussion with the patient going on to a weight loss journey, do not practice obesity medicine. Next, please. Moving on to the next case with uh, obesity. Let's see what her profile is. So this is a 47-year-old female, Mrs. Meena, with weight at 90.8 kilograms and height of 147 centimeters, BMI of 42 kilogram per meter square. Let's see what other comorbidities she has. Well, pre-diabetes, hypertension, hypothyroidism. And trust me, the age factor is very important here. This may be a garden variety case, but we often miss this age group because they are also struggling with perimenopause. And I think it's important to take that into account when we recommend therapy to them and recommend weight loss options to them. So her HbA1c is 6.3%, and EGFR 98 mils per minute, thyroxine 50 microgram daily, and bisoprolol 2.5 milligrams given once daily. Blood pressure is not that well controlled, I would confess. Next, please. And definitely there's need for weight loss. Definitely, we know that clearly it's driving that pre-diabetes, besides the fact that she is in the perimenopause age group and in that stage. And, definitely target HbA1c should be anything less than 5.6, 5.4, basically in the normoglycemic range. And what we found when we initiated, after much discussion and thorough counseling at the beginning itself about potential adverse effects, about everything else, we started tirzepatide at 2.5 milligrams once weekly for 4 weeks, and then escalated to 5 milligrams given once weekly again. Found that her adherence was also very good, and she had started finding some motivation to get into physical activity and increasing it every day. Next, please. Yes, so similarly, there was definitely acceptance of therapy, and the patient's motivation level was increasing. It can be pretty, it can be a bummer in this age group because, again, the mental health of the patient in this age group is, in fact, at any age, in any age group is important, but particularly so in this subpopulation. Because we know that the beginning of pre-diabetes and menopause, again, there is a chance of depression, there's and weight gain. That's the perfect storm for multiple metabolic and lifestyle changes as well. So here too, gradually over 4 week period, we got her to 10 milligrams per week. Next, please. And I would say that although there was improved appetite control and post-meal glucose level as well, the weight loss was not substantial. There was definitely some weight loss, but over 3 months, we found that she was able to lose only 4% of her baseline body weight. Baseline body weight, just to remind you, was 90 kilograms. Next, please. So there was a reduction of almost 5 kilogram per meter square in the BMI, which is definitely, anything is better than nothing. Yes, she hasn't been able to reach her goal of 5 to 10% weight loss, but that's for us to counsel and understand what's going on and how can we optimize the outcomes along with tirzepatide. Next, please. HbA1c reduction was phenomenal, and the patient was in remission for sure with tirzepatide, continued tirzepatide use over 3 months. Next, please. HbA1c at 5.6. And overall, if I have to, summarize here, the 4% weight loss achieved in the first 3 months is a good beginning. I will not say we have reached our goal at all, but we did optimize. We did a thorough diet review, optimized her protein intake, and also increased the fiber intake. There was a lot of erratic lifestyle that she was still following because she did mention that she was not able to sleep well as well. Remember, this patient is not that young. He's 47, mid-age, and a lot of multidisciplinary counseling and follow-up is very crucial for such patients. As far as GI tolerability goes, uh, did not complain of anything, was able to manage everything, and was able to go up to 10 milligrams of tirzepatide. In fact, I am quite hopeful that with further dose escalation, she might even respond much better. We've optimized everything else, and with dose escalation further going up to 15 milligrams per day, she will definitely break that modest weight loss that she has achieved. But in terms of glycemic control, I think it's phenomenal. She didn't need anything else, and she is at 5.6 currently. Next, please. Yes, like I said, dose escalation is something that I would definitely recommend for her, and monitoring of her glycemic as well as other metabolic parameters also, and reevaluation of body composition as well as other long-term outcomes at 6 months to a year is something that we recommend for every patient. Next, please. So with that, I thank you very much for this wonderful opportunity.